Hi, I'm Max Cleland, head of the Veterans Administration. It's my pleasure as head of the VA to introduce these videotape presentations prepared under the interagency agreement between the National Science Foundation and the Veterans Administration. Under this program, the two agencies have joined forces to accelerate the use of ultrasound diagnosis as a tool in medicine. Among the many astounding and diverse scientific advances of the past 20 years, the development of this non-invasive medical procedure seems to me to be one of the most exciting. I find it exciting because it's another field in which the Veterans Administration healthcare system played an early and important part, just as we did in nuclear medicine. The first practical compound ultrasound scanner was developed in 1951 at the University of Colorado using $45,000 in funds provided by the VA. I find the concept exciting too because this technique represents such a useful procedure for examination of almost all organs of the body. With ultrasound, a trained professional can differentiate various kinds of tissues from each other and can detect and identify changes in any tissue resulting from disease. Ultrasound is one of the most valuable diagnostic tools available to us. It is painless and harmless to the patient and relatively inexpensive to use. I hope you enjoy watching this presentation.
Diagnostic ultrasound is a safe and non-invasive technique for visualization and measurement of the fetus in utero. The fluid surrounding the fetus in the amniotic sac provides an excellent path for the ultrasonic waves. With diagnostic ultrasound, fetal growth and maturity can be evaluated throughout the pregnancy, the number of conceptuses can be determined, and the placenta can be localized. HYDATIDIFORM moles, fetal deaths, fetal anomalies, and evaluation of the fetus in disease states can also be diagnosed by ultrasonic techniques.
The patient is scanned in 1 or 2 centimeter intervals. The pubic symphysis is a reference mark for horizontal cross-sectional scan. The midventral line is a reference for longitudinal scan. Pregnancy can be diagnosed as early as 2 weeks after conception. Ultrasonic portrayal also demonstrates whether or not a developing pregnancy is within the uterus or extrauterine, such as in an ectopic pregnancy. The growth of the conceptus can be followed serially from 4 weeks from the last normal menstrual period to term. Prior to 16 weeks of gestation, fetal growth and development are estimated by measuring the gestational sac and the evaluation of the size of the fetal parts within.
From 14 weeks on, fetal growth and development are evaluated by measuring the average biparietal diameter, by measuring the average thoracic diameter, and by taking an average weight of the combined biparietal and thoracic diameters. One of the most important uses of ultrasound in obstetrics is the measurement of the fetal head. An accurate measurement can usually be made regardless of the position of the fetus. In general, the biparietal diameter and average fetal thoracic diameter or average abdominal diameter should be within 0.5 centimeters of each other. If there is a mild to moderate growth retardation problem, then the fetal head measurement will be greater than 0.5 centimeters when compared to the average transthoracic or transabdominal diameter. In cases with severe intrauterine growth retardation, the average biparietal diameter will be the same, but the pattern of growth will be smaller than suspected for the norm. The normal biparietal diameter grows at a rate of 3 millimeters per week from 16 to 32 weeks, and 1 millimeter per week from 32 weeks on. One must suspect a cranial anomaly such as hydrocephalus if the fetal head grows at a rate greater than the norm.
Fetal gestational evaluation is also important in determining the time for elective cesarean section and in determining the gestational age in those patients for therapeutic abortion. Before 12 weeks of gestation, evaluation of multiple conceptuses is based upon the visualization of more than one gestational sac, or after 16 weeks, by delineation of more than one fetal head and chest. Difficulty is encountered when there are more than 3 fetuses in the uterus. To adequately evaluate the placenta with regard to its intrauterine location, the patient must totally fill her bladder so that the lower uterine segment is well delineated. The bladder acts as a water path for the ultrasonic waves.
Placental delineation is important in those cases in which bleeding occurs during the pregnancy to determine the following: whether or not abruption of the placenta might be present, whether or not placenta previa might be present, and for delineating the placental position so that accurate amniocentesis may be undertaken to sample the amniotic fluid both for maturity and genetically. At this point, the use of real-time scanning is extremely helpful for placental studies. The use of real-time scanning allows the definition of placental position without the patient having to move or empty her urinary bladder. Thus, the fetus and placenta maintain their relative positions, and an amniocentesis may be done safely. Also, the use of real-time permits accurate sampling of the entire placenta so that the possibility of abruption may be ruled out. Molar vesicles, being fluid-filled, reflect sound energy as multiple white echoes. This creates the visual impression within the uterus of a snowstorm effect. Variations in the sensitivity of the scan settings while the mole is being studied help delineate characteristic molar spicules.
The detection of intrauterine fetal demise has been made relatively easy by the use of ultrasound. With the use of real-time scanning, the accuracy of this technique has been further heightened. The use of real-time has allowed us to directly visualize the fetal heart and evaluate whether or not fetal heart activity is present. The lack of activity by the fetal heart as early as 10 to 12 weeks is diagnostic of fetal demise. The recognition of fetal anomalies deals primarily with cranial structures. However, with increasing knowledge of anatomy and the use of grayscale techniques, abnormalities such as congenital absence of the fetal kidney or abnormal enlargement of fetal structures can be recognized. Gross neurological defects such as meningomyelocele and the absence of fetal limb structures can also be demonstrated. Recently, recognition of fractures of the fetus occurring in utero in disease processes such as osteogenesis imperfecta have been demonstrated.
The classic diagnosis of anencephaly can be made by scanning the fetus along its longitudinal axis. The absence of the fetal head structure, with demonstration of normal thoracic and neck structures, is diagnostic. When horizontal scans are done in the area of the fetal neck, only an amorphous mass is found. This ultrasonic technique is extremely helpful in those cases where polyhydramnios exists and the fetus cannot be outlined by palpation. Routine evaluation of fetal kidney size and shape has become commonplace. By the use of real-time scanning, the ability of the kidney to function, filling the urinary bladder, is now being investigated. The absence of fetal renal function is demonstrated by failure of the urinary bladder to fill. Disease processes such as meningomyelocele and/or spina bifida are recognized by studying the vertebral column both longitudinally and horizontally, especially with the use of real-time technique. Also, in the use of real-time, the characteristic relationship of the fetal head to the fetal trunk are demonstrated. Rh isoimmunization and diabetic effects are manifested by thickening of the fetal thoracic and skull outline and deposition of fatty tissue or fluid material between the skull and the scalp. In standard leading edge studies, as well as grayscale, concentric circles rather than a single circle represent the outline of the fetal skull. This concentric circle shows the deposition of fatty tissue or edema. Ascites may be recognized within the fetal abdominal cavity if the disease process is severe enough, especially in those fetuses affected by Rh isoimmunization. This is visualized as a sonolucent area between the fetal bowel and anterior abdominal wall. Scanning technique and patient position for the gynecological scan are the same as for the obstetrical scanning. The patient is scanned in 1 or 2 centimeter intervals, depending on the size of the mass in question. The landmark and labeling are also the same as that used in obstetrical scanning. The pubic symphysis is a reference mark for horizontal cross-sectional scan and the midventral line for longitudinal scan. The full bladder technique is used. This enables the bowel, which is normally gas-filled and therefore energy attenuating, to be pushed out of the way. The bowel would otherwise obstruct the view of the pelvic viscera. The full bladder provides a water path which allows the uterus to be viewed in its position directly behind the filled bladder. The bladder also acts as an internal reference standard to compare the density of the structures under question with the density of the liquid-filled urinary bladder. This can be done with both B-mode and A-mode techniques. With B-mode technique, the structure in question is studied to determine at what sensitivity the posterior wall can be demonstrated. The more dense the structure, the more gain will be needed to show the posterior wall of the mass. This sensitivity setting is compared to the sensitivity needed to show the posterior wall of the fluid-filled bladder. This comparison helps determine the density of the questionable structure.
The delineation of the nature of the various masses in question is made more clear by looking at the material within. The characteristic display of a fluid-filled mass is an echo-free zone with strong back-wall echoes. The echo-free zone represents the fluid, since sound flows easily through fluids with little attenuation. The strong back-wall echoes are produced by sounds reflecting from the interface between the fluid and solid underlying tissues. This display persists through changes in instrument gain. In solid masses examined at low sensitivity, an echo-free zone is often produced, but with weak back-wall echoes due to the attenuation of sound traveling through the solid mass. As the sensitivity is increased, the echo-free zone will fill in with multiple smaller echoes characteristic of the varying densities within. In masses such as dermoids, fibroids, or solid tumors of the ovary, multiple echoes can be seen within.
Unlike obstetrical scanning, there is no fluid-filled mass which contains the study structure. Rather, we are studying objects behind a fluid-filled mass and trying to relate them anatomically to their normal pelvic position. In the longitudinal scan, which is the classic reference scan for gynecology, the pubic symphysis is the first bony structure seen. Directly behind the pubic symphysis lies the fluid-filled urinary bladder. It appears as a homogeneous structure outlined in white. The uterus is located behind the filled urinary bladder. The uterus appears black, surrounded by a grayish-white outline. It measures about 8 centimeters in length, by about 3 centimeters in anterior-posterior diameter, and about 4 centimeters in width. The uterine structure is smooth and appears almost to have the shape of a normal light bulb, cut in longitudinal cross-section. It is easily recognizable in most normal patients. The vaginal canal is irregularly seen, depending upon the size of the uterus or other energy-attenuating structures. If identified, it can be seen adjoining the lower part of the uterus and appears purely as two lines parallel to each other. Because the vagina is accessible to direct vision of the gynecologist, the role of its ultrasonic evaluation is essentially nil. The normal ovary may frequently be seen with grayscale and usually measures 3.5 centimeters by 2 centimeters by 1.5 centimeters. It was not recognizable by bistable technique because of the fact that the bowel overlies the normal ovary. Even with the filling of the urinary bladder, the bowel was not pushed away enough so that it might be directly visualized. With grayscale, however, there are enough density differentiations to allow ovarian visualization.
The bowel structure is visualized as a fine white echo pattern, somewhat snowstorm in appearance, and is not separated by large dark areas of space. When the bowel is pushed away by large amounts of black and homogeneous echo pattern, this usually indicates fluid between the bowel and is diagnostic of ascites. The normal, non-pregnant uterus is an echo-free structure. The use of ultrasound to localize structures within the uterus has become increasingly important with the advent of the intrauterine contraceptive device. With ultrasonic technique, these contraceptive devices can be easily and simply identified and localized by the clinician.
Smooth muscle tumors of the uterus are either benign or malignant. In general, any given muscle tumor is relatively homogeneous when studied by B-mode bistable techniques, but with grayscale we'll have multiple echo reflections within. In contrast to more cystic structures, the white outline of the leiomyoma is usually somewhat irregular or filled with echoes. By decreasing the sensitivity settings, the posterior wall of the mass becomes poorly outlined due to the fact that the leiomyoma is quite dense and is markedly energy attenuating. If one looks at a uterus in cross-sectional pattern, either longitudinally or horizontally, marked areas of irregularity or breaking up of the white outline may be appreciated. A-mode portrayal of the leiomyoma again will show a near and a far echo, but unlike cystic structures, as the sensitivity is gradually increased, multiple fine echoes are seen between the near and far side of the tumor because of the whorl-like pattern and changes in density within a given leiomyoma itself. Enlargement of the ovary is one of the most common disease processes that requires ultrasonic evaluation. Even in the routine pelvic examination, an enlarged ovary may be impossible to differentiate from or separate from the normal uterus. In order to distinguish it from the uterus must be identified as a recognizable entity related to the posterior wall of the bladder. The adnexal structure must then be recognized as being lateral, posterior, or anterior to the uterus.
Ultrasonic studies are usually performed to recognize adnexal structural abnormalities. It is important to recognize that the role of the ultrasonographer is not to make a pathological differentiation as to cell type, but rather just state that a mass, which has or has not been palpated on pelvic examination, is definitely present. Simple ovarian cysts are usually well outlined, homogeneous throughout, and have the same approximate density as a fluid-filled urinary bladder. There is no evidence of any adhesions above or below, and therefore strongly suggests a benign cyst. Usually, the cystic structures, which are simple in nature, do not have septa or lines within, though they may occasionally show evidence of internal septate areas.
In the interpretation of malignant ovarian disease, it is important to recognize the normal bowel pattern. Normal bowel appears as a fluffy, whitened area separated by minimal amounts of black, homogeneous tissue. The fact there is normalcy of bowel does not always mean that a tumor is benign, but suggests only that there is no acidic fluid present. In malignant ovarian disease, there may be denser walls of the ovary, which is suggestive only, not diagnostic of, malignancy. If, however, there are areas of dense, white tissue outside the ovary and in or near bowel, this may represent metastatic disease to the bowel and mesentery with adhesions, causing the denseness or marked whiteness and large areas of homogeneous black, which may represent acidic fluid. Bowel that is separated by acidic fluid is almost pathognomonic of malignancy. When one finds a patient with what apparently is ascites, it is important to differentiate by ultrasound acidic fluid from a large, fluid-filled ovarian cyst. The differentiating point is that bowel floats within the acidic fluid, whereas in the ovarian cyst, the bowel is pushed outside the fluid-filled mass. There is a definitive capsule seen in the fluid-filled ovarian cyst.
Another advantage of using ultrasound is in the treatment of ovarian lesions or pelvic carcinomas by chemotherapy or radiotherapy. The anatomical mass can be outlined by ultrasound and the skin areas marked for the best ports by guiding it with ultrasonic delineation. As treatment is carried out through whatever modality is chosen, ultrasound can monitor the shrinking of the mass and therefore direct more effectively the radiotherapy. It can also show that if there is no shrinking of the mass, perhaps the modality of therapy should be changed.
The use of ultrasound in gynecology is a much more difficult, tedious, and time-consuming procedure than that when done in obstetrics. However, the aid and assistance in the pathological evaluation is very rewarding. For the first time, the clinician can conceptually visualize what heretofore he's had to palpate only by his hands.